We were previously talking about the signs and symptoms of asthma, and if you're curious why I have this absence of wheezing highlighted in red, you would think that might be a good thing for the asthma patient, right? Because wheezing is the sound of air moving through a constricted airway. But I have it here because you're kind of thinking of this as a progressive asthma attack, and if someone's right in the middle of an asthma attack and they're having this audible wheezing that you can hear without a stethoscope just from the room, all of a sudden the wheezing stops. It's not because they've gotten better, it's because instead of having a partially occluded airway, it's completely closed off. So that's why I have that here. When someone's wheezing a lot and then all of a sudden they have an absence of wheezing, it can mean that they've gone into acute respiratory distress and they're not moving any air now. The primary goal of medical treatment in asthma is to control the asthma so that functional limitations and risks are reduced. Medical care comprises 4 components. The first, assessing and monitoring the asthma severity and control. This is sometimes done by using what I have here is just the peak flow monitoring. So that might be something that's prescribed for a patient to monitor that. It's kind of like checking your blood sugar every day. So in the morning they would check their peak flow and write that down. The number 2 step is called education for a partnership in care. Research has demonstrated that education for self-management does improve outcomes, so making sure that patient education takes center stage. Thirdly, we want to institute control of environmental factors and comorbid conditions that affect asthma. There are some environmental factors that can't be helped, but there are things that can, depending on the triggers. So identifying the triggers would be the first step in this. I know my son, he had allergy testing done, and one of the triggers that we identified was dust mites. And so how we took control of the environmental factors is we eliminated all of the carpet in the house and removed cloth curtains from his room. And we use special mattress covers for his mattresses. And that's our way of controlling environmental factors. Sometimes you can avoid triggers, like maybe not going outside when the pollen counts are high. Skin testing is a good way to determine specific triggers in the environment, and sometimes patients can be started on what we call allergy shots, and these are desensitization shots, and that does just what they say. They desensitize them to specific irritants. So my son was a good candidate for that. We identified numerous tree, grass, and weed pollens that he was allergic to, and so every week he gets allergy desensitization shots. So a very, very small amount of allergens are injected, and over time, and scheduled for 5 years, he should develop some tolerance to those so that they cause fewer problems. Comorbid conditions include all the patient's other medical diagnoses, including reflux. That was also a problem my son with asthma had. And so, real simple, he takes Pepcid every night. So to avoid the reflux, the reflux was causing him to have asthma at night. Also, we elevated the head of his bed slightly on blocks to reduce the reflux. Obesity, sleep apnea, sinusitis, stress, depression, all of those, managing those can improve asthma symptoms as well. The 4th step is medications, long-term control and maintenance. Anti-inflammatory agents that include glucocorticoid agents, those are considered long-term control. Patients take those whether they're sick or not to prevent asthma attacks. Same with leukotriene inhibitors. My son takes one of those, Singulair, very popular, Montelukast is its generic name. Accolate is another one. Mast cell stabilizers, such as a cromolyn inhaler or nasal chrome, which is a mast cell stabilizer that's inhaled nasally. Long-term beta-adrenergic agonists, such as salmeterol. Occasionally, xanthines are used, like theophylline. And systemic glucocorticoid agents, although those are limited for 2 weeks. So systemic glucocorticoid agents, we have to watch out for side effects, whereas the inhaled glucocorticoid agents don't have nearly the side effects. For acute symptom management, they're going to have their what is termed rescue inhaler, which is usually albuterol, and this is used on a PRN basis. in addition to the other medications. Nursing interventions during an acute asthma attack would include supporting the patient in a Fowler position. It's easier to breathe when you're sitting up. Give O2 as ordered. Again, remember, O2 is a physician's order. We treat it like a medication. Administer prescribed bronchodilators and monitor for improvement. And a lot of times we encourage patients to have a plan. My son has a bronchodilator plan for when he's at school. When he gets short of breath, the plan is he takes 2 puffs from his rescue inhaler. Wait 5 minutes. If the symptoms are no better, he can repeat. Wait another 10 minutes. If symptoms still haven't improved, he uses the inhaler a 3rd time and goes to the emergency department. So a lot of patients will have a plan like that in place, which is good. If you're an ER nurse or you're with a patient that's having an asthma attack, it's important to remain with the patient. Don't leave them. Call for help, but do not leave the patient. They need someone with them at all times. Seek immediate medical care. If no response, just like I said with my son's plan, if there is no response after the 2nd use of the inhaler, that's when we go to the ER. Teaching, we've already talked about ABGs, which are going to tell us a lot more about what's going on than a pulse ox. Suctioning, again, the inflammation is going to cause them to overproduce mucus, so suctioning might need to be done. Making sure the patient's well hydrated, because they are going to be making more secretions. We don't want them forming mucus plugs from those secretions becoming too thick. And try to reduce anxiety, which can be difficult because when someone can't breathe, it causes a great deal of anxiety. Let's do some sample questions regarding asthma before we move on. This one I pulled from your study guide. What is one reason the opening of the airways constrict in patients with asthma? And we talked a little bit about this. I did not specifically stress the smooth muscle, but the bronchioles are lined with smooth muscle, and sometimes we call it bronchospasms, but the contraction of that smooth muscle is what closes off the airway or makes them more narrow in asthma. This is another study guide question, a serious complication of bronchoconstriction. And bronchoconstriction means we're not going to get enough oxygen in. So hypoxemia, low oxygen in the blood. Here is a case study. A client arrives in the emergency department with an episode of status asthmaticus. Again, just to review, that means asthma attack that's been unrelieved by interventions. What is the nurse's priority action? So we have choices: obtain a set of vital signs, administer oxygen at 21%. Well, we should know by now that I already told you room air is 21% oxygen, so that one doesn't even make sense. Place the client in a high Fowler's position, or obtain equipment for starting an IV line. Raising the client to the high Fowler's position would be the initial act, and certainly don't leave the patient, which wasn't on there. Yeah, we need to get the vital signs, and we probably do need to give them some oxygen, although I would think more than 21%, which is just the oxygen component of room air. And we might need to start an IV line, but the first thing we need to do is get them sitting up and try to help them breathe as much as we can. The nurse is assessing a client who has frequent episodes of asthma, which assessment finding is most closely associated with asthma. So here we have some different lung sounds: fine rhonchi, pink frothy sputum, bilateral wheezing, or bronchi that clear with a cough. And I already told you that when we're talking asthma, wheezing is the thing that we're going to be focusing on. Wheezing is the sound of air moving through a constricted airway. The bulk of this chapter and the bulk of respiratory problems that you're going to observe in patients has to do with COPD, chronic obstructive pulmonary disorders. They're the 3rd leading cause of death. There's 2 different branches of COPD, chronic bronchitis and emphysema. When I was in nursing school, these were treated separately, but now they're both just subcomponents of COPD. They can occur independently or together. And COPD is characterized by airflow obstruction and hyperinflation that is non-reversible. So what is hyperinflation, you may be wondering? Here I have a picture of, this is representing an alveoli, and hyperinflation just means that air trapping is occurring in each of these little microscopic alveoli, and the air that's trapped is high in carbon dioxide. So the COPD patient traps carbon dioxide. So the problem is their carbon dioxide is too high. It's not necessarily beginning with oxygen starvation, although when these alveoli are so full of carbon dioxide, there's no room for the oxygen to enter. So that's why breathing more quickly or taking bigger breaths doesn't help, because the problem isn't a failure to get enough oxygen, it's a failure to eliminate enough carbon dioxide. I'll start with the chronic bronchitis branch of COPD. Chronic bronchitis is bronchial inflammation characterized by increased production of mucus and a chronic cough that persists for at least 3 months of the year. Here I have that, for 2 consecutive years, as well as impaired ciliary action. Again, cilia are those microscopic hairs that help move the mucus towards the mouth so it can be coughed out. So people have to meet this time frame in order to be officially diagnosed with chronic bronchitis. Again, chronic cough for 3 months of the year for 2 consecutive years. The inflammation can be caused by inhaled irritants, including cigarette smoke, and it causes blood vessels to dilate and the mucosa to become edematous. At first, only the large airways are affected, so the bronchial, but smaller airways are eventually involved, so that would be the bronchioles. Mucus obstructs the airways, causing CO2 to be trapped in the distal portions of the lungs, so we call that hypercapnia. Ventilation is impaired, so the carbon dioxide levels continue to rise. Oxygen levels therefore go down, because if you think of carbon dioxide and oxygen kind of on a seesaw, as one goes up, the other has to go down. The lungs, because the lungs are hyperinflated due to CO2 trapping, the pressure in the alveoli is greater, and this can cause the blood that's flowing from the right side of the heart to become backed up. When this happens, it creates a type of heart failure that is referred to as cor pulmonale. So right-sided heart failure due to pulmonary disease. You can have different types of heart failure, but the one that's related to COPD is called cor pulmonale, and that makes sense. It has that pulmonale in it related to the pulmonary disease. Signs and symptoms. Often these patients are called blue bloaters due to the fact that cyanosis is often present, peripheral edema or weight gain, jugular vein distension, and exertional dyspnea or wheezing. Again, exertional dyspnea means getting short of breath with any type of activity. If we run ABGs on them, we'll find low oxygen, high CO2, and acidosis as a result of the accumulating CO2 in the system. So again, often this patient is called the blue bloater, and that will help us distinguish from the emphysema patient, which we'll talk about next. Our other branch of COPD is termed emphysema. Emphysema is a degenerative non-reversible disease characterized by the enlargement of the airways beyond the terminal bronchioles, which means the alveoli also become hyperinflated, but it's not due to the chronic inflammation like it is with the chronic bronchitis. In the emphysema patient, the alveolar membranes actually break down and become permanently damaged, so they have fewer functioning alveoli. The main symptom of emphysema is dyspnea on exertion, which shared with the chronic bronchitis, and as the disease progresses, the patient may also develop dyspnea at rest, so constant shortness of breath. The patient presents often as being thin or may have muscle wasting, and it's obvious that they're using their accessory muscles to breathe, again, almost breathing with their shoulders, it might appear. They have a barrel chest from that overdeveloped use of the diaphragm, as well as the air trapping that's occurring. Unlike chronic bronchitis, patients often have normal ABGs until the disease is very advanced, and so therefore their skin doesn't have the cyanosis like what we see in the chronic bronchitis patient. So that's where we get the term pink puffer. Their skin doesn't become cyanotic as early in the disease, and they seem to be shorter of breath even when not during exertion, so that's where we get the pink puffer. And then here you can see the barrel chest. And emphysema is almost always associated with cigarette smoking, whereas chronic bronchitis is sometimes and is not sometimes. I have brief time for a couple of questions. Blue bloater is associated with advanced chronic bronchitis. And this one brings out the barrel chest, which is in quotes. So when you think barrel chest, think emphysema. The term pink puffer is used to describe some patients with emphysema who have normal skin color due to normal arterial blood gases.